as the sun sets down. I bring the greetings from Indian Society of Professional Social Work, ISPSW, and Indian Palliative Medicine, IPM, for second day of series of webinar on introduction to the palliative care. As the family system is eroding from joint family system to nuclear family system, and now it is the trend that individualization is happening. Natural love is not found in present days. There is a question: who cares? Who cares? Who cares for the chronically ill geriatric individuals? It is the responsibility of the care professionals like us to care for them. Yesterday I was young, but today I am old. So the process of aging is going on with everybody. So let's not neglect the elderly with chronic illness. Now I request Dr. Nandakumar to give the welcome note. Now I want to tell about Dr. Nandakumar. Dr. Nandakumar Singh is Assistant Professor and Head, Department of Psychiatric Social Work, Gwalior Manasik Arogya Shala, Gwalior, Madhya Pradesh. Now I request Dr. Nandakumar Singh sir to welcome the gathering. Now I request Dr. Nandakumar sir to welcome the gathering, please. Dr. Nandakumar sir is not there?
He is muted.
I request Dr. Nandakumar sir to unmute yourself, please. Please
Hello.
Unmute yourself. Yes, sir.
Hello. Am I audible, sir?
Yes, sir. Yes, sir. You're audible, sir.
Now it is audible.
Yes,
Thank
sir.
you, sir. Thank you. Thank you. And namaskar to everyone. Today is the second day of the webinar, and this webinar is going on the collaboration with the Indian Society for Professional Social Work and IPM. And yesterday there was a brilliant sessions by the madam. Everyone would appreciate the sessions, and today I hope you people all appreciate the sessions, our sessions of the show. So I welcome all the participants, speaker and organizer on the behalf of Indian Society of Professional Social Work and IPM. So I request everyone, please listen carefully and appreciate the session. Thank you.
And now I want to tell about this program. In this program, people from India and abroad, I think from Dubai, from Africa, from America, and Bangladesh, people want to join, and they are in this program. So I feel that this program is very useful for everybody, and this program is the need of the hour, should be incorporated with the social work discipline. So it is my vision, let this vision grow from today onwards. Now I request now we will go into the technical session. Now I request Dr. Anwar, Director of IPM, Director of IPM. Let's hear his lecture.
Can you hear me?
Yes, sir. It's audible, sir.
Okay. Hello?
It's audible, sir.
Okay, now let me introduce myself. I am Dr. Anwar Hussain. I am the President Director of the Institute of Palliative Medicine, that is IPM, popularly known as. And it is a WHO collaborating center in long-term care and palliative care.
So we are doing a good job in. We are the first to come up with the idea of community-based palliative care. That is very popular model in the world. It is known as the Kerala model. It was originated in our institute, and we do implement and monitor, mentor these programs in different parts of the world, being a WHO collaborating center. So thank you for inviting me, and I will directly, because it is just a 1 hour session, so I will directly go into the class. Yesterday, I think there was some technical issue with Dr. Lulu Matthews. She was telling me to brief a little about palliative medicine in the initial part of the presentation. So I'll be taking 10 minutes to tell about what is palliative care for those who couldn't hear it properly yesterday, and those who were absent yesterday. So because without knowing palliative care, what is the basics and philosophy of palliative care, it is injustice to the psychosocial issues of a patient in advanced care. So I will share my screen about introduction to palliative care first. Can everyone see this one? Hello? Hello?
It's visible, sir. It's visible, sir.
Okay, that's good. So, the problem with Google Meet is that when the presentation is going on, you cannot see what's happening. So if there is any issues regarding audio or video thing, presentation or slides, just can unmute and let me know, because I can't see the chat in this window now.
Yes, sir.
So it is difficult. So anyone can intimate me about anything.
I request all the participants not to present, please. Yesterday it happened like that. Please don't present.
Yeah, don't click on the button present, and also please unmute all of your mics. All of you, please unmute your mics. In the last, we will give 10 or 5 minutes to have a question answer also. So at that time, we will have it. Now, any other questions are there, you can put it in the chat box. We will answer as possible, or later through mail or something. So I'm directly going into the presentation. We all have to die one day, of course. That is one of the most certain things in this world. And only 10 to 15% of us die suddenly. That is, just have a slow and gradual end of life. And during this gradual end of life, most of us suffer enormously. And on our last days on earth, it's not going to be easy, because recently a UK-based company did a study on quality of death among 80 countries, and India was 67th. That means only in 13 countries people die miserably than in India. Because we may be in the forefront of many things in the world, but in the quality of death, as they say, all's well that ends well. So most of our lives doesn't end well. That's a fact. That's the statistics. That's the data. So we are all going to suffer most of us are all going to suffer in our last days on earth. And most of us will be having severe pain, old and alone, need support to move or even to sit, need support for anything and everything, be restricted to our bed, have a sudden loss of income, hopes and dreams, loss of role in family and alienated from the society, be thinking seriously about the purpose and meaning of life and death. So that when we are declared with an uncurable disease and days are numbered, you might be thinking about the purpose, meaning, about God, about after-death life. So that things will come into fore. Yes, we are talking about our own lives, not about any patient or somebody lying on the deathbed. That is currently preceded by 10 years of ill health, and that is increasing. You can see the graph in females. Years of ill health are increasing by every 10 years. So Most people with chronic disease live and die miserably. That is Steinward. He is an icon of palliative care, and Dr. Clark. So there are over 13 million people with incurable diseases suffer unnecessarily. That is a word I want to stress. Unnecessarily from severe pain and other symptoms each year. So much is known of the management of these symptoms, but unfortunately this knowledge is not benefiting most of those in need of it. In spite of all the efforts over the last 2 decades, the great majority of the terminally ill individuals who need care are not getting it. That means we have the knowledge, but they are not getting it. Most of the patients with non-curable disease will have physical problems, social problems, emotional problems, and spiritual problems. So palliative care, I think you are, Sam, you are sharing the slide, right? The participants?
Yes, sir.
Okay, then you can go through. I don't want to read all these things. It's just what is palliative care in brief. So you can go through it later. And this is the WHO definition of palliative care: is approach that improves the quality of life of the patients and their families stress there, facing the problem associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems. So we see the patient as a total, and see that it's a total. We see the patient as a total being, not as a patient or a diseased organ. And this is a team effort. There should be doctors, nurses, social workers, spiritual leaders, psychologists, psychiatrists, friends, family, volunteers, government. All people have to interfere in the care of a non-curable patient to improve the quality of life of the patient, because medical fraternity alone cannot address the problems of a non-curable patient, because the problems are dynamic, vast, varied. So a teamwork is necessary to address the problems of a non-curable patient. And curative and palliative models are, this is a popular graph there. In the end, you can see a rectangular column where it is the end of life care. The curative care starts from the beginning. Palliative care also starts, but the curative care comes down, and the importance and significance of palliative care goes on the rise. And in the end, during the end of life, before the death, only palliative care is left. The need is that our aging world is a global phenomenon. 1/4 of the population of the developed world and 1/10 of the developing world is now about 60. That is why the COVID hit America very badly, because 1/4 of the population were aged. So in 25 years, 25% of the world population is expected to cross the 60. That is a huge burden on the working class of the young generation, because 25% of the world population will be dependent on the working class healthy population. So that is a big data there. We are aging not just as individuals or communities, but as a world. In 2000, over 60 crore people worldwide are 60 and older, triple the number in 1950. By 2009, it has crossed the rest, and it is divided. So in children also, most of the conditions require palliative care. Overall goals of palliative care is to eliminate or reduce the symptoms and discomfort, to improve the quality of life of patient and the family, to improve mood and the well-being of the patient, to provide social, financial, and spiritual support, to improve quality of death. Maybe you are hearing first time the word quality of death, because we always hear the word quality of life, because we have to improve the quality of death to die well, to provide dignity in life and death. So these are the main goals of palliative care and what we try to do. This is a WHO graph of, in a single nutshell. They have put it beautifully, what is palliative care and what is the need and how it should work. So you can refer it to this graph later. So anyway, the sun will set, let it with charm. So this is a presentation about what is palliative care in very, very brief. This is a session I take for 4 hours and I had to cut it short for 10 minutes. So let's move on to the main topic of today, that is I will close this window now and open the next slide. Hope everyone is understanding and present.
Yes, sir.
Thank you. Can you see the screen?
It's visible, sir.
It's visible. Okay, thank you. So, psychosocial support for people with advanced disease. This is a topic assigned to me today, and the presentation will be of the topics will be what are the psychological problems, what are the social problems, understanding the problems, and what can be done. Sam, before that, I would like to know in general about who the participants are like. Or are all they
Yes.
social workers or doctors
Yes,
or
sir.
nurses?
Doctors are not there, sir. Doctors will be 10%, and 90% will be MSW students and teachers.
Okay, thank you.
Yes, thank you, sir.
So I will be going into the medical details of the things. I will go straight on to the psychological problems and social problems, and understanding these problems and what can we do. This is how I framed my presentation. And problems in advanced disease, as we saw in the last presentation, the patients with advanced diseases have mental, physical, social, financial, and spiritual problems. All are important. Today we are taking, in this presentation, we are going to address the two in red, that is mental and social problems. Before that, I would like to introduce you to a patient of ours, who is David, 33-year-old in Menlo Labor, diagnosed with a progressive neuromuscular disease. He is now back home after getting discharged from the hospital and rehabilitation. He needs support to move around and also for his daily living activities. He is on a catheter for passing urine, and David has two children aged 8 and 4. So a very young family, a working class person, financially poor, immobile. So just keep this scenario in mind before entering into the topic. We will discuss about it in the last part of the presentation. So the general conditions of patients like David are, concerns are, will my sickness be cured? We have seen that the patient is in a progressive neuromuscular disease. So the first concern of the patient is, will it be cured? Can I walk again? Can I move again? Can I go to work again? So there are the concerns. Is this leading to death? How would my last days be? If not, if I'm not going to come back into my life, will my last days be suffering? How will it be? Will it be painful? Or will I be abandoned, isolated? Is this due to any fault of mine? That is a spiritual thought, like I did any wrong or any fault to God or to any human beings. So, is it because of that I'm getting this state of physical condition? Is the treatment of any use? Is there any treatment for this condition? Are more problems in store for the future? And why me? It's a very important question because in young patients, we always see, I work in a field where I see dying patients almost every day. It comes from 1 year to 80, 90, 100 years. So in between this age group, we see a lot of death every day, and we try to make them die well, try to improve the quality of life and quality of death. So this is a very important question among young patients. Why me? Because the patients, the people or my friends are moving around of my age. They are playing, they are going to the movies, they are having fun, and I am in a deathbed, not able to drink a drop of water, not able to move an inch. So why this is happening to me? It's a very difficult question to answer. And will I turn into a burden for my family? It's a very important question there. Because when I used to ask in my lectures, how would be personally, because this is not interactive, participants in my class, how would be like, there are three types of death. There is a sudden death, and like heart attack or suicide or homicide or accidents. And there are gradual deaths, like gradual is divided into two: gradual unpredictable and gradually predictable. In predictable, there are some cancers or something non-curable disease which you can predict at least 6 months, 1 year. You will be living for 6 months, 6 years. Anyway, it is predictable. In non-predictable cases, it is like diabetic complications, diabetic foot, neuromuscular diseases. It has a very varied graph. It can progress, it cannot progress, it can be slow, it can be fast. So it is unpredictable. So when I ask the people, if God gives a chance to choose between these three types of death, what will you choose personally? 99, more than 99% of the people says, I would like to die suddenly. The two major reasons for that choice is they don't want to suffer and they don't suffer. So will I be a burden for the family? Will I make them suffer? So let's enter the topic. What are the psychological problems? The problems related to the sickness, anxiety about the future, financial worries, fear about the family's future, and isolation together creates a serious psychological condition troubling the patient. Guilt, disappointment, anxiety, depression, fear, anger, despair, restlessness, pessimistic feelings, self-hate, low morale, concerns related to death and dying, fear of death, reflection on the past life, sense of injustice. That's what I was talking about. Why me? As if God has done an injustice to him. Worries about the, of course, after that they will worry about the after death life. What is going to happen there? Is there an after death life? Is there a hell? Is there a heaven? Is there a reincarnation? We don't know. So what are the social problems? Social problems, any physical illness will have a social impact on them. But when it is incurable, it is long term, the situation is much worse. The problems are isolation, solitude, loss of role. Loss of role is very important because we are all known by our roles. Like I am a doctor, I am a son, I am a husband, I am a father, like we are all known by our roles. When you are bedridden, when you can't move an inch, your role is lost. Your role as a husband is lost. Your role as a wife is lost. Your role as a father is lost. Your role as a mother is lost. So we lose our identity there. Loss of job, lack of social life, broken friendships. Most of the people in their initial phases, when they are in Kerala especially, we get a lot of paraplegic patients due to the coconut trees, palm trees, and the building construction. Many people fall from height and have injury and have paraplegia and are bedridden for lifelong. Most of them are young. So initially, their friends will be there, relationships will be there, relatives will be there. They will be carrying them, taking the hospital, and carrying them every day. But soon, so very fast, they detach themselves. And if they forget him, that's natural, but that happens. Understanding the problems, mental illness are very common among our population. Approximately 7.5 to 10% of the population have some sort of mental problem at any point of time. So prevalence increases with medical illness, disability, and loss. When you have a loss, a person or a property or anything you love, you are disturbed mentally. Very few people get through cancer. Yes, of course, in our society, cancer is a very taboo, very fearful term. So whoever contacts the disease goes through a severe mental distress. Distress, of course, we all know. Someone has opened, unmuted the mic. Please mute your mic. Distress is, of course, a multifactorial, unpleasant emotional experience of a psychological, social. Many definitions may be there. You will be much aware of it more than me. Types of psychological distress are psychological problems and psychiatric problems, as you all know. You know the differences exactly. Who is more likely to be affected by this advanced disease, mentally affected during this advanced disease. Females, due to in studies, females are more affected. Single, separated, divorced, or widowed, living alone, lack of social support, children younger than 21 years, economic adversity, poor marital or family functioning. All this category of people suffer more than the other people. Factors relating to the disease at the time of diagnosis, of course. When the diagnosis is made, you go into a shock, a psychological crisis, a free fall, and after that, you cope with the situation, you regain your composure. But when there is a recurrence of the same disease, especially in some cancers, after the treatment 4 or 5 years later, cancer can come back. During that time, they go to a mental shock or shutdown. During advanced stage of the disease, when initially that disease may not be advanced, so they start the treatment, and when the treatment doesn't have effect on the disease, and it becomes an advanced non-curable stage, during that stage also these patients can have a mental breakdown. Poorer prognosis initially in the diagnosis itself, more treatment side effects when they start chemotherapy or radiotherapy. They start the side effects of the treatment. It is very worse. It is very traumatic. So during that period also they have a mental breakdown. Greater functional impairment and disease burden, experiencing lymphedema, chronic pain, all edemas,
Sir,
yeah.
excuse me, sir.
Yes.
People are saying that the voice is low, sir.
How about now?
Yes, sir. Yes, sir.
Is it okay now?
It's okay, sir. It's okay, sir. Thank you, sir.
Okay. Thank you. Sorry for experiencing chronic pain and fatigue. What can we do actually? This is the most important part of the topic, I believe. Can you hear me now clearly?
It's audible, sir.
Okay.
Thank you, sir.
We have a 90% of the people in our society is going to be in need of palliative care in near future, including you and me. So it's a teamwork, as I told you. So the relationship between the carer and the patient is essential for the patient to share the personal. The confidentiality is important in this relationship. Whoever you care, your father, mother, neighbor, or your patient, whoever it is, you have to have a very confidential relationship. If you go and tell his problems to others and share with others, his confidentiality will be lost, and it will adversely affect the relationship, rapport, and trust between carer and the patient. So only in a setting of trust can a patient share their private feelings, especially their guilt, spiritual problems, sexual problems, personal problems. If they want to share it with you, they should feel that you are confidential, you are trustworthy. Remember that you are just a support to the patient. You cannot do much to this advanced patients. We are never going to make him walk again. We are not going to bring them back to life again. But we are just a support for the patient and the family. We are not going to make wonders in their life. You cannot do anything simple as that. So remember that you are just a support, but that support is very important. Remember that your role will be to a compassionate presence, not just a presence, but a compassionate presence. Explore what is the topic, what the patient wants to know, wants to talk. Usually in our scenarios, we are a paternalistic society, especially in the medical field. We talk and they hear, we decide and they listen. We dictate terms and they oblige. So it is in this setup of our palliative care, we usually let them talk and let them say what they want actually. And do not compare with other patients. Comparison in any case with anyone is very bad, all of you know that. Do not offer a premature reassurance. This is again one important mistake we all make. From sympathy or empathy, we tell them that we will take care of you, we'll do everything, we will do everything possible, we will make you happy. No, you are not going to do that, you cannot do that. So don't make a premature reassurance. Make them say, or say to them when you are absolutely sure about what you are going to do and you can do. And do not prevent the patient from asking difficult questions. Of course, you all have felt that in your professional life. To die, what will happen to my child after my death? So there will be a lot of difficult questions from their side, and they will say some uncomfortable things also. They might be angry at you, shout at you, show some bad faces at you, but you should never prevent them, because this is such sort of reactions are you know that better than me, that such reactions are just they're venting out, and they are actually not a question but a vent out mechanism. And inquire whether the patient is in the mood and mindset to talk before you talk to them, or is it. And a very important issue is admit that you don't know, because as I said earlier, the trust is very important. And if you like blindly say something which you don't know, and with your ego in mind, later when they Google it and all they came to know from another authentic source, the trust will be lost. So if anything, any simple thing or important thing, if you don't know, just say that I don't know, and I will refer it or ask someone, and I will say it, I will answer you later. So never say yes to something is no. So do not criticize the carer for treatment, getting the current treatment. That is, this also happens in the field. We have a lot of volunteers working with us. So some volunteers do make this mistake. That's why I put it this slide for you. And never criticize the treatment. They might be, because there are a lot of treatment options, especially in India. There are a lot of options for any disease. So they might have chosen a treatment which you might not like. So never criticize them for that. Just make them understand in a good way if you feel that that treatment is bad for the patient. And do not destroy their hope, because they don't have a hope actually, because their hope of living is no more. Their hope of walking again is no more. Their hope of a cure is no more. So what is actually giving a hope? Hope is that, I will talk about it later in class. You can give a hope you will not be abandoned, or we will be there with you, we will try our best. That is not a silly hope actually. For a hopeless person, whatever you give is a hope. So do not confuse the patient and family by suggesting other treatment and magic remedies. Again, in India, there are a lot of magic remedies with religious people, with superstitions. There are a lot of things happening around, and these are all hearsays. Most of them are hearsays, and there are no magic remedies as for a non-curable disease. All of you know that. Otherwise, people won't die. So don't confuse them telling about those magic remedies and all the hearsays. When you take a leave, tell the patient and family when you plan to visit again. This is again important, because most of the time initially we say that I will come next week, but we would have never planned to come next week, because we want to make them happy. We say that I will come tomorrow, but you have no plan to come tomorrow. So just say them if you are coming, and if you are planned to come, just mention to them. That's all, and ask for the visiting convenient time and date. I would like to mention in a brief about the ethical principles of caring a patient. This is very important, and this is very rarely mentioned in our classes. This is important for any carer, because autonomy is the principle of respecting one's autonomy. Like every person has the right to choose or deny any treatment. That is dependent on me. If I have a disease, I have the right to choose the treatment or not go for the treatment or not to go for it. So that is a very important thing. And he has the right to know about the diagnosis and doesn't know about the diagnosis. He can choose whether to know or whether not to know. So that is very important thing about autonomy. Beneficence is that whatever you do for good. Like whatever thing you are planning to do for the patient, it should be. And third one is, even if you cannot do any good, never harm the patient. And justice is, if you are a social worker or in charge of an institution or a center, you should use the resources in fair and equality. So these are four major. This is again a topic. This single slide is a lecture of 2 hours. So I just wanted to mention in between this, because you should know this. The patient has the right to decide. We always should do good to the patient, never try to harm the patient. Do justice to all of your patients. And identifying the distress, routine case detection is unreliable in detecting their mental distress. Usually in hospitals, they don't give much importance to mental distress. They always are inclined toward the physical distress, identifying them, understanding them, and addressing them. But mental distress are always sidelined, though it is very important. Early detection of the mental problems in any disease leads to much better intervention possibilities. Levels of distress can be matched with interventions. So if you intervene early, you can have address the distress much better and earlier. May improve the medical outcomes. If you identify the distress earlier, it can also influence the outcome of the treatment. Reduce the healthcare cost. It can improve the patient quality of life and satisfaction of the family also. And again, our mood and emotions are heavily influenced by our thinking and our behavior. Our thinking alters and we view a situation in a negative, unhelpful way, our mood will likely to alter and drop. So they say that it's all mental. You might have heard in English they say that it's all mental. So our thinking can lead us to behave in certain ways, like avoiding or withdrawal. I will explain in the next slides. You will understand it better. The meanings and belief of an individual holds about their illness thoughts will impact how they feel. Of course, there is an Austrian psychiatrist. You might have heard about him, Viktor Frankl. His family was executed by Hitler in gas chamber. He was a Jew. He was a psychiatrist, and he escaped from his family. His wife, children, father, mother, everyone died in that gas chamber. And after that, he wrote a book called Man's Search for Meaning. And in this book, he states that every suffering without a meaning is destructive. Suffering without a meaning is destructive. So if any suffering, even in our lives, any crisis, relationship issues, financial issues, any problem, any suffering in our life, if we cannot attach it to a meaning for that suffering, it can be destructive. That's how people end up in suicides and depression, because they can't find a meaning for the suffering. Like that's where the religion and spirituality has a very important role. Most of the religions and spiritual thoughts, they attribute a meaning for a suffering, like they have done something in their past life, or they will get something in their afterlife. So there is a meaning before or after death for a suffering which is going through in this life. So that's a bigger meaning, higher sense of meaning. And even in our lives, we attribute meaning. Maybe something bigger would have happened. It just happened this much. Maybe if I would have gone, it would have been much worse. So we attach some meaning and belief systems. These systems have a very important role in the impact in how they feel and act. So this is thoughts to distress. I don't know how you have seen this graph. thought is that if say example we take the patient David. David is, as you have seen, very young, with a young family. So he thinks that his thought is that my life is over. There is no point in trying anymore, and that comes to behavior. He withdraws from everything, social life, from the family, from talking, from being enjoying him. So leads to emotions, depression, hopelessness, and this is a vicious cycle. And again the physical sensitization. It has its impacts on the physical. It increases the pain, fatigue, because he's already depressed, he's already detached. So this is a very, very important vicious cycle where a thought can lead to. The trigger factor was a thought. David thought that my life is over. There is no point in trying anymore. From that thought, it came that he isolates himself, he withdraws himself, goes to depression, and that eventually increases the physical suffering. And this is a slide where it's opposite to the previous thought. Thought to care. Thought to care is that David thinks that my life won't be the same again, and things are going to be tough. But if I work at it, I can still achieve things. So this is something which opposite to the previous thought, that there is a positive there. And this lead to behavior, seek support from the family, plan change. So I will share a very personal experience. 2 weeks back, one of my friends, he is a doctor. He had a very severe back pain, and we all thought that it was due to disc prolapse or IVDP. And in the MRI, it showed that there was some mets. He was a very healthy, very energetic doctor. And there was some mets, and again, further investigations finally led it to acute lymphoblastic leukemia. So I could see from he's a very, very positive person. Initially, he was a little down, but later he came to think that these are going to be my most important days in my life. I am going to fight, and I am also going to live and make use of what is left in me. And a beautiful sentence he told me, that he messaged me, was like, we say that life is unpredictable, but when it becomes uncurable or you are going to die, it becomes predictable. So beautiful. So you can predict it, and you can count your days, and you can make use of your days. So that is a very positive thinking you can instill in all our patients, that whatever has left, we can make it beautiful. So it changes their behavior. They seek their support from the family. They start talking to their friends. They make plans for treatment and curative plans, and also to make use of the rest of the days. And emotions, sadness becomes determination. He moves into fighting mode, and this eventually changes in decreasing the physical pain, even in the course of the altering the course of the disease. This is another. You might have seen this model of care. That is mild to minimal distress. You can go through this graph. In extreme distress, you have to have the help of the psychiatrist. In minimal distress, you can have your own team of counselors, or even the supporting staff, or even family can do this. And also in between, there are different stakeholders for the care. You might have seen this. This is a distress thermometer. This is not a thermometer. It actually is an imaginative, conceptive thing. 0 is the least distress. They can imagine comparing to their own life itself in the past. What was your most happiest days that you can, or most distressless phase? You can name it as 0. And if you think of an extreme distress in your life, which you can imagine it or you have gone through it, what is extreme distress, and where you stand in between these two, 0 and 10. Some people say I'm okay, fine, I'm okay 2, 5, it's much worse, 8, 9. So they can compare it to their own experiences in the past life. And this is the WHO Wellbeing Index. World Health Organization has Even all of you can do this exercise, and there are scoring systems. They indicate each. I felt cheerful, good spirit. You can read that later in the slide, and you can score your marks. And depression is considered as a possibility of a raw score is below 13. If total score is 13, consider that you are depressed. Or if the patient has answered 0 to, they have skipped many questions and answered only 0 to 1, not answered at all, or have just answered one question, and even the mark is 5, you have to consider him as depressed. So when you share the slide, you can do the exercise for you also. Practical approach for such patient is identify and get an estimate level of distress using any methods, using the distress thermometer or this WHO index. Using any tools, you can identify and get an estimate of the level of distress, how much he is in distress, and create a problem list and prioritize. You just randomly write down all his problems and prioritize the problems, and depending on the severity, address each issues as appropriate. And creating a problem list, let the patient create the problem list. Ask them to write down their problems and prioritize them. Ask them to write them. You should ask an open question, like what are your main difficulties at the moment. So they will be writing a log. Then summarize for them and group together as appropriate. You can divide it into different groups: mental, physical, spiritual. You have all those sorts of all these problems. You have immediate problems, acute problems, chronic problems. So you can categorize them according to their problems and encourage the patient to prioritize and break down in all those problems into small chunks. And say, if an example, if David has been asked of what are your problems, he might say that I am anxious about, David is not a cancer patient, sorry, any cancer patient, anxiety about cancer, he has pain, he is worried about the family, he has financial problems. So priority is anxiety. So you have to explore and address the most prioritized problem in his life, because priority is different for different people. Two patients with the same age, same social background, same race, same sex, same diagnosis, same stage of the disease might not have similar problems. For some people, it might be a daughter's marriage before his death. Some may be the debt he has had from the bank 2 weeks back. What will happen to the debts now? Some might be constructing a new house, and in the last stage of the house, he might have contacted the disease, and he is very much apprehensive whether I can live in that house. Usually, we get a lot of requests in palliative care. I want to live in that house at least for 1 day before I die. Some people make it, some people won't. So they have different problems. For some, it might be a spiritual problem. He might not mind anything. He might not have any financial problems, or he is not afraid of cancer, but he is afraid of after-death life, or he is concerned about his guilt. I have been doing such bad things in life, so what will happen to me? So priority is very vast, varied, subjective, and relative. It can change from time to time. It can change from people to people. So prioritization is important, and you have to rework on prioritizations. It is not a static thing. It can change during the course of the disease. It changes with the disease, with the problems. So priorities can change. So we have to recheck frequently the priorities and deal according to the priority of the patient, not according to the priority of the treating team or the priority of you. That is very important. Treat, address the patient according to the priority of the patient. That scenario again, this is coming back to David. Maybe these are the possible problems he might be having. His mobility is affected, activities of daily living is affected, his finance is affected, personal relationships are affected, social activities, health and social care, accessibility, he cannot go to the hospital, or get a quality healthcare even for minor ailments. Transport, he cannot go anywhere without the help of anyone. Work and capacity to work, home environment, especially in this paraplegic patients, home environment is very important because they cannot, due to the construction of the house, they cannot move even inside the house. They may be in a difficult position. So it's all home environment is very important in people like David. And carer issues. There is, you have seen that he has two young children, maybe a young wife, and all the burden is on the wife now. Mentally, physically, she will be exhausted. And sexuality, of course, people like David, I will be dealing with sexuality in detail. And what can we do actually for mobility, all these problems? Maybe mobility, we can address it with a wheelchair, with supportive systems of volunteers, for activities of daily living. In Kerala, we have a lot of volunteering going on. It is one of the largest volunteer organizations in the world. We have more than 1.5 lakhs of trained volunteers in palliative care in Kerala. That's a huge, huge number. Actually, Kerala, in India, Kerala have only 3% of the population, and 97% of the palliative care happens in Kerala. That is again a huge difference with the rest of the India. And mostly this success story is attributed to the involvement of the volunteers. That is, local people, laymen, society, families, communities came to help the patient in need in their advanced stages and during their last days. That is, a huge help is outside the medical fraternity. So again, 75% of the patients in need of palliative care gets in Kerala. The Indian data statistics is less than 5%. Again, in India, only 5%, less than 5% of the patients get palliative care when they are in need, compared to the 75% in Kerala. So it's a huge difference. So that's why there are a lot of volunteers are coming here in my slide. So even in college students, not medical college, arts and science college, engineering students, management students, all come in our institute to learn and help the patients. So again, all the problems have different solutions and different teams, different stakeholders. And so, as I told you earlier, it's a teamwork. And sexuality is a very important thing, especially with patients like David who are bedridden, paraplegic, or progressive neuromuscular disease. This is rarely addressed in the society because of the sensitiveness of the issue. Most of the females are not ready to talk about it in our villages. So very often in many cultures, carers find it difficult and embarrassing to explore sexual issues. You cannot explore it. If you cannot explore that, you cannot address it. So there may be misunderstanding about whether the disease will spread. The disease might cause one's attitude. As we said, that due to some psychological problems, mental breakdowns, they may not be interested in sexual activities. Deformities of the sexual organs, treatment itself, fragility of the body, lack of privacy. Again, in our villages, the home will be small, there will be lack of privacy for some people to have this physical relationship, and their colostomy, tracheostomy, so on. And what can we do in this for this? You have to explore any problem to address that, as I said. Make sure that the patient gets the time and privacy to spend time with the partner. Encourage the patient to open up his problems and needs. In case of patients with diseases that are transmitted sexually, allow them to discuss with the doctor about the safe methods of sexual intercourse. Conclusion of my topic, supportive communication is very important, and as I said earlier, your compassionate presence. The patient needs to realize that she is still wanted in this world, still deserves a lot of love and respect, and under no circumstances will she be abandoned. That's a very important thing, that you won't be abandoned till your last breath. We will be there with you. So listen, some of the qualities I would like to bullet it like this. Listen attentively, be a good listener. Do not consider the patient's problems as insignificant, always happens with people like us. Do not force your opinions, beliefs upon the patient. Do not ignore the patient's queries. Try to address the social issues that can be addressed. Do not give any false hopes. Ensure confidentiality and do whatever you can. Thank you. Sam, you are muted.
Yes, the presentation was awesome. Thank you, sir. Your explanation was simple, enlightened our understanding. It created knowledge base for linking palliative care and our discipline social work. Thank you, sir.
Thank you.
Your enriched words
Any
has
questions? We have 2 minutes
yes,
left.
your enriched words gave us insight on palliative care. I request the participants to raise the questions in the chat box. The questions are: 1. How the palliative care is affordable during the COVID-19?
No, it's a very good question. We are finding it very difficult, and that is the only hope also. People cannot move out, they cannot go to the hospitals, and the only thing is the home care system. And I forgot to mention that in Kerala, with all these success stories, we have a huge home care system. There is only 4 admitting institutions in Kerala throughout their homes. So we have a very established home care system, and that is running fairly good now. And we all have protective masks, and we have set up a lot of guidelines for that, like whether their travel histories, any relatives have come to house with contacts, any contact history. So we have a questionnaire to assess the patient before visiting the patient, and if he is in a safe zone, we visit them with our protective measures, and we are doing a good job. We visit around 20-25 patients in my institute alone, and throughout Kerala, palliative care is doing a good job with COVID patients also. Sorry, not with COVID patients, but other patients is in this COVID scenario.
The next question is: what are the guidelines for palliative care in institutional setting?
It's a very difficult thing to have palliative care in institutional setup, because we don't get the desired benefits of palliative care when you institutionalize palliative care. That's what's happening outside Kerala throughout the world. Even in UK, where all this palliative care setup started, it's institutionalized. This community-based palliative care is a new thing to the world. We have been practicing it since last 20 years. So institutionalized palliative care is difficult because they have to spend a lot of money and manpower to have a person admitted in the hospital, and you don't know when this patient, how long this patient will stay in the hospital, when will he die. So the comfort zone is always their home. So try to build a community-based, home-based palliative care. That is the best thing. If you are not able to do that, just make sure that your hospital offers a free treatment for such patients who are.
The next question is: do you train the volunteers in Kerala, like Trivandrum and Alappuzha?
Yeah, we definitely, yes. We are one of the most WHO, being the WHO collaborating center, we train a lot of volunteers, doctors, nurses, and we have in the last year itself we have trained more than 60,000-70,000 volunteers in palliative care. So,
and
that's for the main.
There is another question. It is what is the role and responsibility of caregivers in palliative care?
That's a big question, actually.
Yes,
So you can find some of your answer for some of your questions in the slide itself.
Yes, sir. Yes. And another person has asked, what are the techniques to overcome the psychological problems?
Again, it needs another class.
Yeah. Uh,
So maybe later we can have another session on this.
yes. And another person has asked, what are the basic assumptions of palliative care in Indian perspective?
Yeah, assumptions. It's different with different category of people. Like for doctors, it is different. For a layman, it's different. Uh, for a patient, it is different. So actually, what happened in Kerala was this importance and significance of patient palliative care was much more understood by the layman than the doctor community. So usually the palliative care, usually I skip that slide in this. For many people, it is the end of life care. It can be a holistic care. It can be a destitute care. It can be a pain management. So there are different concepts of different in different places about palliative care. But in short words, I would say that palliative care is improving the quality of the patient and the family of a new and curable illness. In simple words, by a team of doctors, nurses, and volunteers, trying to improve the quality of patient and their families by a team of doctors, nurses, and volunteers.
It is a last question, sir. A person has asked, is there any assessment of the clients and the family in palliative care? Is there any assessment like this psychosocial assessment in palliative care?
Yeah, we do have different tools to assess the questionnaires and tools to, as I showed that in the distress thermometer and all this. We have different tools to assess the psychological conditions. And I would like to mention that we are starting online courses maybe in 1 or 2 months. You can see it in our website. All these courses we are converting into online courses, so you can check in and find the appropriate courses for you. All there are a lot of courses coming up, so you can sign in and check out which course is suitable for you and do the course so that you get a better understanding of. Also, I would like to respond through my mail about the